Welcome to the Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we have a very special guest, Ashton Maaraba. He is the president of Bonum Health. Ashton, welcome to the program.
Thanks, Tom. Thanks for having me. I appreciate it.
Ashton, tell us a little bit about Bonum Health and their presence in the healthcare market.
Sure. So Bonum Health is a telemedicine company. We sit in the telehealth space, but we are a pure telemedicine play. We have an end-to-end solution that continues to grow. We cater to the uninsured and the underinsured patient population. Our platform sits on the SureScripts network. So we have physicians on the platform, a little over 650 medical providers that are board certified and licensed that write prescriptions to pharmacies across the U.S. That cover all 50 states. We're a very unique program in that we do have other elements that traditional telemedicine providers do not have. That's pretty much our platform.
Tell us a little bit more about those unique differentiations that others may not have.
So one of the things that we thought would benefit the patient community in today's day and age is to combine a telemedicine platform where you allow the doctors to speak to the patients and write a prescription for that patient to go to that patient's pharmacy of choice. But on the other side, we found that a problem was the cost of prescription drugs. So one of the things that we did was we started partnering up with the prescription discount cash card companies. And that seemed to bode very well for our user base, for our registered users and our subscribers. We are a subscriber and an encounter-based platform, which means that patients can subscribe to the platform so they can use it frequently for a low cost that appeals to the entire household. They get up to 5 visits per month. They also, if they do not want to subscribe, they can access the platform and use it just once. What makes us unique, on top of using the prescription cash discount card, not only do they get the prescription, but if they're a cash paying patient and they do not have insurance, they can also use the cash discount card provided to the pharmacist. And when the pharmacist is filling the prescription, they can apply the discounts against that prescription. And at some point, at some levels, they can save that patient up to 80% off what they would have paid. So what we did was we combined the low-cost access to our prescribers for patients that are suffering from non-emergent illnesses with the benefit of having a prescription discount element. So that we thought was a big winner for us and for our patients. We also leverage retail pharmacy as our distribution partnership. One of the things that we learned as we built and designed Bonum, we didn't want to just compete against your traditional telemedicine providers. We wanted something that can appeal to pharmacy, which is really the pharmacist is the number one trusted out-of-office care provider today when you look at the total healthcare system. And we knew that pharmacists were always looking to diversify their services that they're offering to patients. And we also know that the cash patient is growing considerably at the pharmacy today because of the pandemic and for other reasons. But we also know as well that many patients that do have insurance are suffering from high deductible health plans. So to solve that problem, we customized our telemedicine platform to allow pharmacies to white label it and to offer it to those types of patients that can't get access to, if they're suffering from a non-emergent illness. They don't have to wait 3 or 4 days to see the doctor. They can literally see one of our virtual care specialists at the pharmacy, inside the pharmacy's consultation room, or in a mobile remote area. One of the things that we did with the pharmacies is that we customized our back-end platform so that way we allow a promo code that the pharmacies can provide to the patient, which buys down the cost of care. It's volume-based, but it allows the pharmacist to be able to build and further enhance and strengthen their brand loyalty with their patient by offering them a deeply discounted solution or access versus, let's say, the patient going just to a site, downloading an app and not having that relationship with the pharmacy and paying, for example, the MSRP or whatever the published rates are, at that time.
Very interesting on the distribution model. There was an article that I read recently. It was entitled, "There's no substitute for personalized care." And then the headlines just below that states, as the pharmacy industry continues to evolve, one thing remains true. Independent pharmacies will always have a trust factor advantage. It goes on to say, patients often visit their pharmacists more than any other healthcare professional. Thoughts on that?
So the article and the research out there proves that pharmacist is your number one trusted care provider today, hands down. The patients are visiting pharmacies and the retail site much more frequently than they're visiting their doctor, and they're spending more time with their pharmacist. Their pharmacist is more accessible and is available, has hours that are more available today than your primary care. Now, that doesn't mean that the primary care isn't a critical part of the equation. But what it does say is that the pharmacist that caters to a patient's acute illness is much more important today than yesterday in a patient's regimen, welfare, outcomes, and adherence rates, which are all critical factors to reducing the cost of healthcare. That's number one. Number two, when we look at community pharmacy, when you say independent, it's actually, we look at it as a community pharmacist. And a community pharmacist could be an independent pharmacy or could be a chain pharmacy. And the key is the profession and where the profession has evolved. I've always found a need to link that profession to any part of the healthcare system, because when you're dealing with collaborative care, you're dealing with the patient's wellness. It requires all the key providers to intervene in that patient's healthcare regimen. On the telemedicine side, for example, think about some of the areas where we help the patient. Patient anxiety settles when they can't get access to a provider. So we solve that problem right away. We give them quick access to a provider that can treat them that can treat their non-emergent illness and write a prescription within 15 minutes. Something that could have taken 3 days, alleviated, right. Was addressed in 15 minutes. Then comes the pharmacist who gets that prescription, that can counsel that patient and get that patient really revved up to take that prescription as prescribed, and then eventually, hopefully, pick up the refill if there's a refill as well. Typically in the 90th day, when a patient, that's typically the 90th day of a prescription regimen, is when patients start to drop off their prescriptions, where they stop actually using the drug. That's a problem. So the intervention of a pharmacist, because of that frequent interaction, is key. It's why we wanted to connect the pharmacist as a distribution point with our telemedicine platform. It's why we keep also evolving the platform into new areas that I'll probably talk about later on.
Interesting. So you talk about the relationship between the pharmacist and the consumer/patient. This article goes on to say there's no substitute for having a strong patient relationship, and this strength of independent pharmacies, or pharmacies in general, as you call out, is because there is easier to hold the patient accountable for their health when you know them at a personal level. I often talk about on my program that the gap in care, I refer to it as 8,745. The average Medicare patient, 5 chronic conditions, sees 9 different doctors. CMS data, they're only in front of their provider, their entire provider team, 15 hours out of that year. So the question is, what happens the other 8,745 hours? Obviously, the pharmacist plays a key role in that because of the scripts that are written, and as we've called out and talked about here, is that relationship. So part of that ability to keep a patient on plan, if you will, really, I think the pharmacist plays a very significant role in that. What are your thoughts on that?
Well, I'll tell you what, 100% accurate. The pharmacist is a key ingredient to a patient's wellness. And long-term and sustaining that wellness. A pharmacist plays a key role in moving a patient that's suffering from a chronic condition to a non-chronic scenario. Or a pharmacist plays a much stronger role today in the prevention side of the world, catching the symptoms and addressing them before they fester and worsen. One of the biggest problems that we've had in the industry over the years is the fact that all this time that the pharmacist spends with the patient to provide the type of therapy in order to preserve that compliance and to help improve their patient's outcome and to build that trust bond, which is a big part of the therapy. Pharmacists aren't compensated from what we call a value-based care model, or do not have the type of provider status that qualifies them for reimbursement through government plans, as do, let's say, other occupations within the profession that spend less time with the patient and don't have the most optimal outcomes. Pharmacists yield the best outcomes today. And that's a problem. That problem persists on Capitol Hill And Washington's done a much better job in this day and age, but there's still so much more that needs to be done in order to strengthen the opportunity that a pharmacist persists in order to intervene with that patient's therapy, strengthen that trust bond, and continue to focus on the patient's long-term outcome. If they don't do something about it, you're going to see a reversal at some point. We are very, very bullish on a pharmacist intervention. The statistics are there. Not only are pharmacists intervening in therapy and helping that patient stay compliant or helping catch that patient's condition from worsening, there are many patients out there taking medications where the medication may not be working. And if not for the pharmacist intervention and screening of that patient, they would have never been able to intervene and prevent a potential heart attack or a condition worsening.
Yeah.
Those are key issues that when a pharmacist intervenes and goes through that process, they don't get reimbursed. One of the things that definitely needs to be addressed is that government side of it on a much higher scale. Now, the industry is doing a great job of promoting it, but Congress has to really take a much more proactive role at the state level. And their healthcare policymakers, the new ones that don't understand the depth of pharmacy and pharmacy services, need to get more involved because their constituents are the uninsured patients or the underinsured using our platform and going to the pharmacy and seeking that help. So that's a very important issue that continues and needs to continually addressed.
And so when you talk about intervening, you're suggesting that, hey, the provider has this trusted relationship with this consumer/patient, and the pharmacist has that relationship, that they potentially should modify the script in which that patient is taking, change the care plan. Tell us a little bit more about what you believe the definition of intervention should be, or the scope of intervention should be.
There's a few angles to look at this. The first angle is there are states today where boards of pharmacy actually allow the pharmacist to refill a prescription without having to call the doctor. There are some states that allow the medication to be titrated, which means that adjusted without having to actually call the doctor. The type of intervention I'm referring to is more of the screening conditions. If you take a look at the top two critical conditions that patients suffer from today, 66% of American households suffer from either one form of diabetes or one form of hypertension. That's huge. So think about it. 66%. The pharmacist fills on average, the national average is between, I think, 225 to 275 scripts per day. Some stores fill 1,000, but I'm talking about the national average. The patient visits the pharmacy on average, visits the store on average 12 times a month, depending on where you are, 25 times a year on average based on, again, where you are. They're visiting and they're spending on average anywhere between 5 to maybe 10 minutes with their pharmacist on certain occasion. They visit their doctor at most on average maybe once or twice a year, if that, and they spend less than 3 minutes with their physician on average when it comes to an encounter. That's because of what they call managed care contracts or managed care, the way that the system is set up from a primary care standpoint. In some cases, some physicians spend more time. In other cases, in a managed care situation, they spend less. So when a patient's with their pharmacist, whether it's through face-to-face encounter or as Bonum Health is going to be getting into virtual pharmacy care, where the pharmacist can actually intervene with the patient while the patient's at home, no different than the doctor speaking live face-to-face with that patient through our mobile app or through our desktop solution. That intervention on a patient's condition is really important. Just certain things with the interoperability of medical devices today, which is another element that Bonum's getting into, that pharmacist can sit here just like you and I are speaking to each other, ask that patient to sit down and measure their blood pressure 3 times while they sit there and they read that reading, and at the same time measure their results against the medication regimen. Within minutes, they can already pre-diagnose that, look, the medication doesn't seem to be working. You may need a diuretic. You may need something to regulate that. Let me contact your doctor. That's the type of intervention I'm referring to, as opposed to that patient not having that encounter. That's just one of many types of encounters. I mean, right now I'm just talking about the disease, but think about things like obesity, which is the number one risk factor to hypertension. Hypertension
Absolutely.
is the number one cause of heart attack and stroke. And again, I just focus on one disease state, but there are so many others. We're looking at expanding our platform to allow dietitians on there. They can focus on nutritional elements. We focus on women's health, men's health. We're really going to start persisting those types of clinics on our platform, and at the same time connecting the responses to the pharmacist, so the pharmacist can also kind of come full circle, work with the physician on our platform, and really address that patient's overall need from that perspective.
So one of the growing trends, as a matter of fact, there's a separate report out there that talks about remote patient monitoring being the new delivery of care model of the future. And I think the article, if I recall correctly, referenced the future as being 2024. So it's not too far off, if you will. The point there being is it's interesting that you call out the expanding role of the pharmacist and the exposure that they have to the consumer and able to maybe react sooner in intervening in a potential event that would occur. The point there being is remote patient monitoring, I won't use the word misplaced, but should the remote patient monitoring model even from a billing code, and I understand what you're saying, that they don't have pharmacists don't normally have access to that, but the point is that providing remote patient monitoring allows for a more immediate intervention. When you're seeing blood pressure, not even blood pressure in the context of the high and low range, but even within the range of normal, you can see an escalating climb, right? So you can ultimately intervene when you see that, when you're monitoring and see that, to again eliminate the potential ER visit and longer term event. Thoughts on the role of the pharmacist and a pharmacy in the context of providing those remote patient monitoring services?
Yeah, Tom, I think you hit it right on. I think your question is a great one, to be honest. You hit on a topic that, has opened up the significant dialogue across the healthcare industry in terms of what is the most effective part of remote patient monitoring, and how to actually execute and how to get more and more healthcare providers involved. So the biggest thing that I've seen, and I'll kind of try to break this down where I cover each of the key angles, because it's a big issue. I mean, RPM, there's a big picture to this. And if you do it right, you're going to make it easy. You're going to draw the attention of those that first thought it was too much work and realize how simple it is to adopt and how easy it is for us to drive utilization. You can implement anything, but if it's not utilized and if there's no execution from all the parties, it's just going to sit there and collect dust. Something we've learned in pharmacy services and healthcare services over the years. And it has to be turnkey, and it has to be part of the regimen, and it has to be profitable too. And, look, we have to be honest with ourselves. Profiting to us in the healthcare industry should mean that the patient's getting better.
Exactly.
That's what we embrace, right? If the patient's getting better, then those that are delivering and they're part of the care system are also going to profit from a monetary standpoint, and also from ratings and everything else that's key, that keeps that effect and keeps the steam rolling. And the problem is that from an RPM standpoint, we look at it as that if it's not implemented on a stage by stage basis, then you're only going to get a select few that will really administer that type of program. So here's the way we look at it. At Bonum Health, we looked at remote patient monitoring, and we love it. We embrace it, and it's part of our future. And it's also, from our surveys, it's part of our retail partners' future. It's incumbent upon us as a healthcare distributor on the virtual care side, and our distribution partners that are persisting the actual technology, and then the executors on the physician side and on the pharmacy side, to come together and find kind of a segue, a medium, before we take it to the next level. And here's what I mean. We're embracing a strategy where we're going to launch remote patient monitoring light. And under the light philosophy, we're going to focus on clinical screening first. So what we're doing is we're taking home healthcare devices that meet a clinical standard, and we're establishing interoperability to our platform. That means that these home healthcare devices, like let's say Wi-Fi enabled, Bluetooth enabled, or Ethernet enabled blood pressure monitors, diabetes mechanisms, BMI scales, and other aspects that collect data with our platform, the way it's set up. Remember, it's a live EMR, and it sits on a prescription network that drives the prescription directly to the pharmacy queue, the way physicians are used to persisting a prescription and the way pharmacists are used to receiving it. This element drives the opportunity to be able to actually study the patient's vitals. So we're going to start out just with the screening side of things. On our mobile app, we have a whole section that allows us to allow that data to filter into the patient's profile, and then it allows the patient to share that data directly with their care team. So it's very simple. The patient's already on the actual app talking to a physician. They're already using their blood pressure cuff, measuring their weight, Very important to take that BMI score. In fact, it's become a vital statistic. And then at the same time, also, if you're a diabetic, checking your diabetes, making sure that you're doing the right checks on a regular basis, breakfast, lunch, and dinner. That's the type of data that we're going to collect and then make available. We call that remote patient monitoring light. It's up to the pharmacist to intervene. It's up to the physician to work with the pharmacist in that case, and it's up to the patient as we empower patients to take charge of their own health to be able to gauge whether or not they're high. Key indicators today have become a lot easier to differentiate just by a color-coded scale. The scale tells us if you're in the red zone, you're high. If you're in the green zone, you're optimal. If you're in the yellow zone, you're borderline. So patients now can kind of see where they measure up. The key is to alert the provider, whether it's the pharmacist through a remote patient monitoring light or the physician, exactly what's going on with this data. And the key is for the physicians to be able to participate and be more attentive to that data, and the pharmacist as well. And I'll tell you why. Physicians today are not getting enough data on the patient when they're not at the office, when they're not visiting the physician at the office. They need to collect the data that's more in tune to the patient's environment, what's going on in their life, in their lifestyle, when they're not at the doctor's office. The pharmacist plays a key factor and a key role into that as well. That's why remote patient monitoring light is very important to us. That's level one. Level two is your full-scale remote patient monitoring, which I think is more of what you're referring to. That's where we actually have an administrator and we have a collaborative care profile between the physician and the pharmacist, and a contract that's signed between the pharmacist and the physician, where the physician and the pharmacist work together. The pharmacist handles the monitoring outside of the office, reports back to the physician as needed, and then bills the physician based on the fraction of the time that they participated with in helping that patient achieve that outcome. Everybody wins with that strategy. At the same time, there's a healthcare administrator that monitors that patient as part of the process. So there's different ways of managing remote patient monitoring. That's the optimal point. We are 100% committed to investing in that strategy, but that'll be our tier 2, which we're expecting to launch at some point in 2023 or late 2022. So we're very excited about remote patient monitoring, and we think that will be eventually the number one source for contributing to a lower cost basis in the American healthcare system. We are approximately the 26th, I think, or we're 24th in the world. Our healthcare system is 24th in the world. That's our ranking. We're the wealthiest country in the world, and we're ranked at number 24.
It's a sad but true fact. So, this is why I wanted you to join the virtual shift, because Bonum Health is truly shifting the thinking and the execution of the delivery of care. And I am very excited about watching you and your organization accelerate your path into this particular effort. The underlying items that you're calling out is potentially, and you tell me if I'm wrong, is really the regulatory side. We really need to look at the pharmacists and the pharmacy much more strategically in the delivery of care model, as opposed to just a place to go get your pill. Thoughts?
I couldn't have said it better than myself. I think the perception on the lawmaking side has gotten better, in that they understand that it's not their, pharmacists historically were known as the apothecary pill pusher. Yes. Today, they are a therapeutic health guru, therapeutic health advisor, and they're really strong. I mean, I've been fortunate to sit on an advisory committee for a school of pharmacy, and I've been on the National Association of Chain Drug Stores Regional Drug Event Committee for many years, and in Canada as well. I've also supported the Canadian community and even Australia, and it's a common theme, no matter what country you're in. It's the same issue. But the one thing that is definitely improving is the understanding. But they have to eliminate the barriers. And one of those barriers is recognizing on a more frequent basis. I'm not just saying selective, but on a frequent basis, in order so pharmacists can really do more. Some of the things that the state boards of pharmacies have done over the years have been amazing. And we have to credit the state boards because they work very hard for the profession. And Congress, they defer to the state boards on many issues that are being contested at different levels. And the state boards have made it easier. They've given the pharmacy tech. They've certified the pharmacy tech. They've given the opportunity for the technicians to fill scripts under their discretion or the presence of a pharmacist, allowing that pharmacist to spend more time on the therapeutic side with the patient. So that's just one example of many. The other thing, too, is that where we see an avenue for continuing to promote the presence and the advantages that a pharmacy delivers when you're dealing with, let's say, a program like ours. We looked at our telemedicine platform and said, look, we shouldn't just appeal to humans. We should also appeal to vets. And we should focus on, for example, cats and dogs. We need to bolster the value that we're delivering to the household, especially the household that's feeling the budget crunch more than ever. Not to mention the traveling household, the business individuals that are traveling on a regular basis. And look, I don't have time to go see a primary care when I'm on the road for it. So we said, look, we're going to continue to add value for these pharmacies. We're going to try to appeal to the vet side so we make it more useful so patients can see the value of, let's say, subscribing to our platform and then continue that two-way connection. I mean, our strategy wasn't just to bolster the value of our platform, but to bolster the connection that a patient or a household continuously has with the pharmacist. The pharmacist isn't just filling prescription for mom, dad, child. They're now filling it for cat and dog for those commercially available prescriptions. We're really trying to be strategic. The final pivot for us is integrating prescription delivery. So we have that consummate tool that patients rely on. But the one thing I really value about our program when we work with pharmacists, and the one thing I've seen how pharmacists respond to our program, is what they hear from their patients when it comes to what they paid. You can get an encounter with a board-certified medical provider, for as low as $11. That's unheard of. And then you can get that prescription for as low as $4.
Yeah.
That's a $16 turnaround versus $150 or $200 or $300, or worse yet, $650 for going to the emergency room for the same issue in the middle of the night that you could have had resolved by one of our board-certified optometrists or medical providers, doctors, or primary care specialists or pediatricians. We get that all the time. The pharmacists get it all the time. We also get a lot of some of the surveys we've conducted these days. We hear pharmacists that are telling us that a patient thanked them for saving them so much time and for offering our service as a convenient tool. And I know your original question spoke about, as you were summarizing, the legislative side, but it's all full circle because the more the pharmacist is able to do that, the more they're going to be recognized as this, I don't want to say this massive marketplace of healthcare services, but a legitimate marketplace of dedicated services that's taking care of the constituent. And when I speak of legislatures and Congress and these issues on Capitol Hill, you have to look at it as a constituent because we're constituents.
Yeah.
But at the end of the day, it's a patient and it's a consumer too.
Very interesting. Bonum Health, Ashton Maaraba, pivoting and shifting the delivery of care model. Awesome work, I have to say. And hopefully we can have you back on the program. Thanks for joining us and great success in the future.
Tom, thank you very much. I appreciate it.
I would like to thank the show sponsors, both HP and Intel. HP Engage long lifecycle products provide the stability, safety, and security you need, plus flexibility and performance designed for today and tomorrow. As well, Intel would like you to know we're going above and beyond together with new standards for business with the latest Intel vPro processors, delivering what IT needs for performance, security, remote manageability, and stability. And be sure to check out the program page on healthcarenowradio.com. And remember, connect or follow me on LinkedIn, Twitter, @FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.